Yes, ma'am. We are live now.
Yes.
Good evening, esteemed faculty members and all the delegates for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Unexplained Infertility. Uh, Let me introduce the organizer of this webinar, Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also a part of NUHS Singapore, co-founder of MAM and board member of SWWC. So I welcome you, ma'am, and I hand over the session to you.
Yeah. So thank you, Sahiti, and thank you, Shield Pharma, for providing the platform for this program from the constant 3 years. A very warm welcome to all their friends who have joined all across the geography. As we all know, India is having suffering from lot of patients who are getting from the infertility. So to discuss what are the advances, and we all know last time also we have discussed what are the recent advances in the treatment of the infertility. Yes, we are doing the ICSI, we are doing so many other modalities, we are using some latest drugs also, but still, even though after the some reports, the couples are coming to us with the unexplained infertility. So today, to discuss with that, to throw the light on the problem of the unexplained infertility, we are having a stalwart with us. Dr. Padmaja Madam is with us. Padmaja Madam, very warm welcome to you.
Thank you.
Thank you for uh, thank you for accepting the invitation. May I request Saiti, will you please do the honor for introduction?
Yes, ma'am. It's my privilege to introduce Dr. Padmaja, ma'am. Ma'am has done MBBS, MD, OBG in AIMS, New Delhi, and FCGP, FMAS, FICOG. Ma'am is affiliated to Foxy, IMA, FCGB, IMS, and ma'am has received awards like Dr. G.N. Mathur Prize in Physiology, Dr. Rama Memorial Gold Medal in OBG, and Silver Medal in FCGP exam, prize in paper presentation at 4th APCOG at Kurnool, and also Foxy Leadership Award, first prize in All India Essay Competition for Cervical Cancer Awareness conducted by Foxy in 2021, Foxy Dira Award at 16 September 2022, and Dira Award and Certificate of Appreciation from President Foxy, Dr. Shanta Kumari.
Yeah,
And
that's okay.
ma'am has been
Thank you. It will,
the
the
president
others
of
are just, no,
Yeah,
it's enough. Thank you.
ma'am, some more lines we can say na for the patron of the AP for the IFS Society 2024 to 2026.
Yeah.
Besides this, there are so many accolades madam is having. We can't take all because our program time is very short.
Yes.
Saiti, will you please stop sharing? Yeah.
Yeah.
And so once again, a very warm welcome to you, ma'am. Ma'am, all the doctors have joined all across the geography. I am able to see Dr. Samuel has joined from the Africa, some friend from the Kerio, some from the Zurich also, and Geeta Madam from Lucknow, very renowned IVF specialist from Lucknow. Renu Madam, a very renowned doctor from all the way from Kanpur, and so many other dear friends. Dr. Vijay and so many other friends have joined. Dr. Dorji from the Bhutan. So, ma'am, we all are eagerly waiting to hear you. Now, all dais is all yours.
Thank you. Uh, some of the facts that people are not really aware is that Amazon rainforest, world's largest rainforest, covers 2 million miles. It is across 9 American countries and it has 10% of the world's species, 2.5 million species of insects and 1,300 bird species, 3,000 fish and 430 mammals. And it has 40,000 plants. It produces 6% of the world's oxygen. It's a carbon sink. So this forest creates its own weather and influences the climates across the world. But we human beings are managing to cut down these trees that are there for hundreds of years, and you can see a small group of human beings how much of the forest they were able to chop about. So why do we do things like this that are so destructive? Are not, we can't really explain about them. So but infertility is something we can explain. So I don't really like the term unexplained infertility. I think it is that we are not the technology to find out the cause why this fertility issue is there is not available everywhere, and we are not probing deep enough, because if we go deep enough, we will always find an explanation. So we should be saying this, but this is a term that has commonly been used when common simple basic investigations like the semen analysis on a microscopic examination looks normal. We have evidence of ovulation by some means or the other, and we know that the tubes are patent. So when these three are there, because the major players are there, that means for an oocyte which has half the genetic material and the sperm which has half the genetic material, both are there, and there is a way for them to meet. But then it is not happening and there is no fertility. So you call it an unexplained infertility. That has been the label, because these were the only technologies we had to investigate around 40 years ago. And as you all know, inability to conceive after 12 months of unprotected intercourse is for infertility. And 10 to 14% of the Indian population, that means out of every 10 people you meet, one of them is having this, 1 in 6 couples. And that with our huge Indian population, that means there are around 27.5 million couples actively trying to conceive. And out of those, around 10 to 30%, depending upon which place we investigate, we label them as unexplained infertility. As you can see, anovulation is the most common cause. Male infertility is because of 34, and unexplained varies somewhere around 20%. So that means around 1/5 of people, we are not really having an explanation. And that is the category of people who come and tell us they have tried in another place, they've tried to treatment protocols, but they haven't conceived. And when we ask them, what did the doctors say? Because they said everything was fine. So this is a common, and that is one of the reasons why they switch doctors. So everything starts with a detailed history. So when someone walks in like this, what we need to do is look at the duration of fertility, look at all the previous records that are there, go back to the menstrual history. Previously, they might be the woman might be having regular periods, but now she might be missing some periods, and whether she's ever had a pregnancy makes a lot of difference. What was the type of contraception they used? And most importantly, coital frequency and sexual dysfunction. What happens in the busy OPD is the client is there, the husband is there, they come sometimes to their mother-in-law, then other people are walking around. So it is very difficult to talk to them, and they don't reveal these dysfunctions unless they have confidence in us. So we need to give them time. We need to know about previous surgery, hospitalization, serious illnesses, and whether there is any sexually transmitted disease exposure, whether they had any evidence of pelvic inflammatory disease. Now, almost every sixth person we ask, they say, I'm on a thyroid supplementation. So we need to know that. And we need to know if there is any history of abdominal pain, dyspareunia, whether they've had. And remember that we are treating the lady for fertility issues, but that does not mean her health gets detected. So just find out about a pap smear, always ask about allergies, and whether they have any family history, particularly whether there is any family history of early menopause, reproductive failure. Some of them say, my Masi had very late pregnancy. So is there any problem like that? And mental retardation in the male members can also be an FMR mutation, whether there is any history of birth defects. What work are they doing? Are there any environmental hazards? And nowadays, we need to ask the couple about tobacco exposure, primary or secondary smoking, alcohol, recreational drugs, any diet fads that are there. So by this time, we will be able to have some idea about their overall general health. And looking at the WHO 2010 standards, how did we come across these semen analysis and say this is normal, this is abnormal? So the 2010 reference standard was based on semen collected and tested over 1900 men who had whose partner had a pregnancy in 1 year. So those semen samples were taken, the counts were checked, motility was done, volume was done, all of them were arranged, and that is how we had these men were that's how we came to this. The previous one was based on only 400 men, and we have the vitality was based on 400 men, 2 countries. And one issue with this is most of these individuals lived in the cities of the northern hemisphere, and a small set from Australia, and there were no men who were there from the densely populated areas where most of them live nowadays. So when we say sperm count is normal, that means we are talking about anything more than the fifth centile. That means 1.5 ml with 15 million count, total number of sperms in the ejaculate 39 million, motility total 40%, 4% normal form, and vitality 58%. But you remember that this is the fifth centile. That means 95% of people who had a baby had counts more than this. Only 5% of people who had babies had counts less than this. But remember, this is not the average, this is not the reflection. 50th centile means midway. That means where were most of the men? Most of the men were at sperm concentration of 73 million with a 60% motility with 15% normal forms. So just looking at this fifth centile, don't assume that if a person is having this minimum basic, that they will definitely have a baby. And so semen analysis are not good surrogates for male fertility status. What semen analysis tell us is how many sperms are there, how many are moving, how many have a capacity to most probably deliver the DNA material in that sperm head to the oocyte. So the confounding factors is that men's fertility also does not stand still. Like how women's hormones fluctuate, men's fertility potential also is influenced by sexual activity. It is influenced by the secretions from the other glands. It is influenced by other conditions like stress and their exercise and their diet, which might be causing a change in the sperm parameters. And in the semen analysis, we are not looking at the DNA. So even if there is a fragmented DNA, even if the DNA is not so good, but it is well packaged and the sperm is moving, you're assuming that it is a normal sperm. And we are not looking at the oxidative stress that is causing damage to the sperm flagellum, the motility, the acrosome. We are not looking at any antibodies which might be preventing these sperms from going ahead. And sometimes we are making a drastic decision based on single ejaculate. And in the same person, over different times, the sperm count is going to fluctuate a lot. So what is very important is on the day his partner ovulates, what was the count that day? And that is very difficult to analyze. Therefore, we should be at least looking at 2, preferably 3 semen analysis before we make any statement saying that this is perfectly fine or this is very bad. So always say, let's look at it again. And one more thing is, anytime the nature is willing to make a copy of us if we are healthy. So there has been huge epidemiological studies in which they said that men who are having fertility issues, they live sicker and they die younger than normal men. So fertility is also a overall reflection of our health. And decline in sperm counts and increasing in testicular cancer is also being reported. So all of you know, spermatogenesis occurs in the seminiferous tubules, and the basal lamina has spermatogonia which undergo mitosis, and then there are meiosis, and there is spermiogenesis in which a round cell is converted into a motile sperm. and this spermiogenesis starts at puberty, and every cycle of division takes 16 days. So if we were to look at, and whenever the basal cell is there, it divides into two. One of them goes on to become a basal cell, the other one progresses to form a sperm. So every time there is a division happening, that division can have a mutation. So imagine these basal cells in a 75-year-old man would have undergone 1500 total mitotic divisions, and every time there is a chance of acquiring a mutation. Therefore, aging is important not only for the female partner, aging is important also for the male partner. So men who are more than 40 have a higher chance of having de novo mutations. Not only the genetic, the epigenetic phenomena like DNA methylation, histone modifications, non-coding RNA retentions, all these lead to poor sperm quality, which in the children is linked to autism spectrum disorders, and it is linked to the gametogenesis in that child, and which can have an impact even on the grandchildren. So osteogenesis imperfecta also happens to a higher extent in children born to men of advanced age. And as I was telling you, spermatozoa form from puberty throughout life, and to give 100 million sperm per ejaculate, we have 2000 genes that are working to change the shape of the DNA of a round cell during spermatogenesis and spermiogenesis. And remember, only 30 of these genes are from the Y chromosomes. That means all of them are scattered all through the rest of the 23 chromosomes. And because the sperm has to travel for a long distance, the nuclear material of the sperm is wound, and then it needs to be wound even more tightly. So histones are replaced by protamines. And once the semen is deposited in the vagina, the coagulum keeps the semen inside the vagina. The seminal plasma neutralizes the acid environment. The coagulum keeps the sperm protected and close to the cervical mucus so that it escapes the immune cells that are there in the vagina. And cervix has a 3D maze and fold. So this protects the sperm from the microbes, because if the microbes are there, they can hide in one of those crevices. Uterine contractions propel the sperms past the microbials, and fallopian tubes are the haven where the spermatozoa can occur. So after ejaculate, within 20 minutes, sperms manage to reach the tube. They latch on to the folds in the fallopian tube, and they wait for the oocyte so that they can get released and go and fertilized. So the motility, hyperactivation, expression of receptors for the zona happens only in the female reproductive tract, and acrosome reaction, lysis and formation of a hole in the zona pellucida and fusion occurs at the level of the oocyte. So if we are having unexplained infertility from the male partner side, one of these factors is not happening properly. And DNA always can have damage. Whenever there is a DNA damage, the cell, if it is not able to repair itself within 3 to 4 hours, the cell dies. And average 1 million times per day, a cell is having this damage. And these mutations can be repaired in somatic cells. But sperms cannot repair their DNA because they do not have cytoplasm, they do not have the enzymes to repair it, and the sperm DNA is tightly packed and it is inactive. So sperms with damaged DNA can still move, they can still complete the fertilization, and once the pronucleus of the sperm expands, it is the maternal cell that repairs this DNA. So if the female partner is young, this can happen. But if the female partner is also of a higher age group, she cannot repair her own damages and she will not be able to repair these damaged sperms. And so, more number of pregnancy losses very early, which manifest as failed implantation, happen. And oxidative stress is common. It has a physiological role in capacitation, acrosome reaction, hyperactivation, and sperm binding. But when there is a varicocele, when there are lots of leukocytes, when there are lots of immature spermatozoa, or there is exogenous sources like smoking, radiation, alcohol, and toxins, all these can cause lipid peroxidation, DNA damage, apoptosis, leading to male infertility. So, if we, when we are doing a workup for infertility, remember that even if they have normal sperm parameters, look for explanations that could cause unexplained male infertility. And if we have a strong suspicion that there are a lot of reactive oxidative species and they're causing DNA damage, we can do DNA fragmentation and we can check whether our antioxidants are working. And if there is a specific etiological factor, we can treat it. And basically, we need to tell people to quit smoking. Or overweight, obesity, also they need to lose weight. Some of the antioxidants that have a proven role are CE, folic acid, zinc, selenium, and carnitine, and coenzyme Q10. And as I said, we need to treat genital tract infections. And one more thing that works is a very short ejaculatory abstinence. And in utero exposure of the women to environmental and lifestyle factors leads to and exposure to gonadotrophin leads to the male child being born with hormonal dysfunction, testicular dysfunction. So the environment in which a child is growing in utero is also very important. And now we can come back, we can also look at what the female factor has. And as I said, quite a large number of people nowadays are so busy with their life that they leave their entire life how it should be run based on tech. So they have the apps and they tell them today is your fertile period, have your intercourse at this point of time, and then they do only that. So misconception, comprehension about the concept of female fertile window, improper coital techniques, increasing stress leading to erectile dysfunction, all these can cause fertility. So talking to them really helps. Telling them not to stress out whether every act of sex is going to lead to a pregnancy. Sex is a means of intimacy, togetherness, and bonding, and having a baby is a byproduct of that. That is how sex should be. And one of the causes of female infertility could be endometriosis. There can be visible, non-visible lesions, and so the molecular pathology and the inflammatory cytokines and the prostaglandins that are there in the peritoneal fluid affect the oocyte quality. The adhesion, even so, even mild disease can lead to a decrease in the implantation with all the changes in the microRNAs, communication, and the progesterone resistance that is there. So keep at the back of the mind, if there is a chance that she has endometriosis, and one of the ways to be aware about it is do your baseline scan on the day 2 or 3 of the periods, where you can see sometimes a lot of echogenic fluid in the peritoneal cavity, which is suggestive of a reflux menstruation. And then looking for probe tenderness and all will give us some idea in some cases. And as we said, because of the ectopic implantation of the endometrial cells, inflammation, oxidative stress, abnormal tubal function, dysfunction of the oocyte, abnormal endometrial receptivity and implantation can contribute even in mild and minimal. And the sister of endometriosis is adenomyosis. So now 40 years ago, adenomyosis was considered a disease of the 40s after the reproductive life, and hysterectomy was the solution. But we are seeing now very young people also having adenomyosis. So imaging gives us a clue. Looking at a globular uterus, giving under magnification, when we are seeing, if you are not able to see a good endomyometrial junction with spicules, also start suspecting adenomyosis, especially in women who are having severe dysmenorrhea and heavy menstrual bleeding. And look for congenital uterine anomalies. Although they're most frequently associated with recurrent miscarriage, some of them, like a unicornate, decrease the chance of pregnancy. Leiomyomata are there in almost 20%. So when they're submucous, when they're large intramural, more than 5 centimeters, or in the cornal region, they can cause fertility issues. And um there is no shortcut to having a baby at a young age. So as women increase with a lower AMH level, low antral follicle count, and if you have an unexplained poor response to your stimulation protocols, you're giving an ovulation induction drug, but you don't see an ovulation according to the pattern that you were expecting, then in those cases, start looking for low reserve and start investigating early, because here time is the essence. Because as age increases, oocyte quality decreases because of mitochondrial dysfunction, granulosa cell apoptosis, and increased oxidative stress. And that is the reason why aneuploidies are so high. One thing is, sometimes the biological age is higher than the chronological age. That means a woman who is only 25 years, her ovaries can have an antral follicle of just 2 3. That means her biological age might be as high as 35. And if you look at 35, 50% of the embryos are going to be aneuploid. So remember that, have a high index of suspicion. Do we think that this lady has a low reserve? The other reasons are immunological factors, but we don't really have hardcore tests that are accepted all over, where they have randomized trials to say that these are the factors that are need to be tested as such. So we need to look, this is an area of research. And one more thing is tubal factors. On a sonosalpingography or a HSG, when we push in the dye, we might see the dye coming out well. It says the tube is open, but it cannot. There are a lot of variations that are picked up in reality. You can see these small fimbrial cysts, you can see saculations, you can see phimosis, there can be bridging adhesions, there can be tubal cysts, there can be axillary tubes. So when we look at this sort of pathology and you have nothing else to explain, and this work was done in France, when these were corrected, the pregnancies were much, much better. So fimbrial agglutination, and you can see the incidence of these that are happening. And because the subtle tubal lesions are important, because tube form works to regulate the ovum pickup, sperm migration, fertilization, nurturing, and sending these embryos into the uterus is all a function of the tube. So if there is phimosis, if there is an agglutination, doing a neosalpingostomy, removing these bridge edges, led to a pregnancy rate of 58% compared to non-treated people when these cysts of Morgagni were removed in this series where of unexplained infertility. I'm not saying that you should go ahead and do a vigorous surgery, but keep this in mind. And one more thing is, we classically think that the hormones act on the endometrium. But remember that the hormones even act on the tube. They act on how the secretion and transudation is occurring in the tubal epithelium. They act on the ciliated motility of the ciliated cells. They act on the muscle cells, which affects the contractility. And as you can see, Estrogen leads to increased fluid volume, increased ciliary motility, and increased contractility. So what happens is, when the follicle is growing and there is estrogen, it is important in trying to pick up the oocyte, nurture it, and there is spasm of the cornwall region, so that the oocyte is there in the tube for a longer amount of time. Later on, with the progesterone, the tube or cornwall region opens up, and when there is contraction, the embryo manages to come into the uterine cavity. So this fine orchestration of what and how the motility should be happening is dependent on hormones. And as I was showing you, these are all the types of cells that are there in the tube. Tube is not just a pipe which is a conduit, and the interstitial cells of kajal are the ones that cause this smooth wave, and this is one that regulates how the motility of the tube is affected. The other causes, as we already know, dietary and our lifestyle. All of us are eating much more than we should. We're sitting longer than we should. And cervical factors are one of the neglected factors. Cervical mucus is not always like type E, where there is a nice pathway in which it can swim. If there is a cervical mucus which is a little viscid, you can see the sperms are struggling to go. And these cervical mucus can be as fluid gels, they can be loaves, they can be more viscid. And you can see that only at the time of ovulation do we get these nice pathways of cervical mucus which lets the sperms go in. Vaginal flora, when it is abnormal, there is a lot of inflammatory cytokines. There are a lot of macrophages which also can phagocytose the sperm. And when previous surgeries of the cervix, like cauterization or cone biopsies, curettage is done, when there is chronic cervicitis, when there are lesions like cystic fibrosis, and sometimes using multiple cycles of clomiphene citrate, use of propranolol, nicotine, excess amount of copper, iron, and selenium trace elements, all these can cause a hostile cervical mucus. And even the male factor, when there are too few sperms, they will not be able to swim through the cervical mucus. When there are anti-sperm antibodies, the sperms will not be able to swim. And if there is a deficient seminal vesicle secretion, the the semen pH is not able to neutralize the acidic pH of the vagina, and sperms die much faster. Use of lubricants is also toxic to sperm. So vaginal microbiota is what is very important, because uterus is not a sterile region. So whatever are the microbes in the vagina, a part of them will be reflected in the endometrium. And lots of work has been done on the difference in the live births between whenever there was an abnormal vaginal microbiome, and these also have an impact on the decidual reaction, adaptation of the blastocyst to the endometrium to the blastocyst, and how they interact with the trophoblast. So when people say we don't know what is wrong, what we need to think is the follicle growing well? If it is ovulating, is it releasing an oocyte? Is the oocyte chromosomally normal? Is there inadequate luteinization? Is there a luteinized unruptured follicle? Are there empty follicles? Is the fertilization not happening? Is there mild endometriosis, peritubal disease, antichlamydial antibodies, inappropriate transportation? Are we having poor quality embryos? Is there an attempt to implant? Is it a loss? Or is there an abnormal uterine peristalsis? So many things are ones we don't know. And the final pathway that we really don't know what is happening in unexplained infertility is there an abnormality in the ability to implant? Because implantation needs a coordinated work of all the macrophages, stromal cells, cytokines, chemokines, and decidualized endometrium. And these are all the factors that are necessary for implantation, and it is very difficult to see what of these is not working. And this is the area where maximum research is being done. So having said all that, what do we do? Because there are a lot of unknown questions, so there is no way we can investigate everything. So how do we go forward and treat these people? So we have a Cochrane review where 60 full text articles were first included, 27 systematic reviews, and 27 network analysis. And as you can see, there were some biases. And what works is that when we do expected management, out of the pregnancy rates are around 16%. So when we do an ovarian stimulation, it is only 16.7%. That means you just, a person who's ovulating, you give a ovulation and get her ovulation induction drug and get her to ovulate a single follicle, you're not going to do her any benefit. Adding an IUI gives a 19% pregnancy rate. Doing an ovarian stimulation, that means when we suspect that there is a poor quality oocyte that is coming out, we try to compensate for the lack of quality by quantity, and we get more follicles to ovulate. Then we have a 24% pregnancy rate. And if everything else fails, we always have an IVF program where we have almost a 35% pregnancy rate. So this is what we should be telling them. And as I was saying, of course, the more number of follicles we have, the multiple pregnancy rates increase. And the more amount of drugs we use, the hyperstimulation risks are definitely going to be there. So, and if we want to avoid all those, we should know the gonadotrophins that we are using, and we need to work up systematically, do a cost effective diagnostic evaluation, and try to cut down the time to pregnancy, because they've already been through a lot of treatment protocols. So divide in your mind. Do you think she's a good prognosis couple? Do you think this couple it's going to be very difficult? Good prognosis are the ones who have 2 years infertility, the female partner is less than 35 years old, who had a previous pregnancy, and all the others are poor prognosis. And especially when they're in their 40s, whatever the duration of their marriage, it is time to go in for an aggressive management. And of all the factors that say, people ask, if you find really nothing wrong with me, can I wait for a while? So remember, the most important factor is the age. So the younger they are, the shorter the duration of married life. If they have had a pregnancy and we have a means to improve the sperm count, these are the couple who can wait conservatively. And what are the medications we have? If you think you need to use an anti-estrogen, clomiphene or tamoxifen works. If they're obese, because the estrogen in the fat is much higher and there is a lower testosterone, use of aromatase inhibitor helps. If they're hypogonadotrophic hypogonadism, they have the male partner has low FSH, low testosterone, using gonadotrophin helps. What definitely should not be done is use testosterone. And when people have tried ovulation induction, this was a pretty old study, but I liked it for its clarity. So if you can look at the pregnancy rates that occur in CC, the pregnancy rates that occur within 4 cycles. So if somewhere they have used ovulation induction, clomiphene citrate or letrozole and had monofollicular growth for more than 4 cycles, definitely don't do it. and age is a limiting factor. And when sperm count is more than 5 million with more than 30% motility, only then do an IUI program. And the higher the number of oocytes we have, the more is the pregnancy rate. And that is what said. And in this study, this was done pretty much before the era of this hyperstimulation, where gonadotrophins were being used initially in the 80s. So people have seen that when more than 9 follicles ovulated, the pregnancy rate was as good as IVF. But this is something we should not be doing now because of the risk of hyperstimulation that is there, multiple pregnancy that is there, and heterotropic. But I'm saying the number of oocytes it takes to make a baby, try to optimize to try to get 2 to 3 and do 3 cycles of gonad IUI, and one of them they should conceive. If not, we need to shift them to an IVF program, because IVF program will be a diagnosis and a treatment. We know the gonadotrophin responsiveness. We expect a woman to respond to 225 or 300 units of gonadotrophins given for 10 days and have 15 follicles, 10 oocytes, 8 embryos, and she will become pregnant. If she's not, then something is going wrong. And we know how many oocytes come, we know their fertilization capacity, we know the embryos that are forming, we know the ability to have a blastocyst, and then we can transfer that. So to conclude, pregnancy rates are high in women who are less than 30 years. When the number of cycles go to 5, you can see the pregnancy rate is 2%. So there is no point in doing more than 3 to 4 IUI cycles at any point. And when the number of follicles increases, the pregnancy rates increase. And IUI, they should be having at least post-wash 10 million motile sperms. That is when pregnancies will occur. So if a couple walks in with unexplained infertility, first look at the age factor, look at how long they have been married, and if they have already tried expectant management, try a gonad IUI for 2 to 3 cycles, shift to IVF. As the age increases, go on to an IVF program much earlier than, say, to continue to wait. Thank you very much for listening.
Thank you, madam. Thank you so much. Such a comprehensive presentation. You covered each and every point. Let's see if there are any questions. Friends, if there are any questions, you can write in the chat box. Madam, you have concluded with a very nice point. Yes, this is very important, because most of the patients also waste a lot of the time if the unexplained infertility, they are going from one doctor to another, taking the medicines. It's very important to console them and to explain them properly that if the results are not coming, of course, they have to go for the IVF. Madam, we are getting only the appreciation comments.
Thank
Just
you.
a second. Till we are getting the question, may I request Saiti to please show the certificate of appreciation for the madam?
Okay, ma'am.
Wow, thank you.
Thank you, madam. This is a small token of appreciation from our side for contributing as a distinguished speaker. Madam, we have received one more appreciation comments from Dr. Dorji, who has joined from the Bhutan. A very nice presentation. He's writing. So I think there are no more questions, and I think everybody is hungry too.
Yeah.
So friends, with this we will wind up for today. Tomorrow we are having again a very interesting topic on the sexual health counseling and how the gynecologist can deal with the sexual health patients. So do join tomorrow at 9 p.m. I will post the link. I will post the link by tomorrow morning. Yeah. So thank you once again, madam, for sharing your immense knowledge with all of us. And thank you, my dear friends who have joined all across the geography. And
Thank you, Ritu. Thank you, ma'am.
Yeah.
Thank you. Good night.
Yeah. Hi, Anu. Anu, good to see
Hi,
you.
hi. Hi, dear. I was in consultation, but immediately I joined. It was
Yeah.
very
Hi,
nice
hi.
session.
Yeah. Hi,
Very
Dr. Ajit.
informative.
Yeah. Yeah. Hi, Dr. Samuel. How are you?
Fine, thank you, ma'am. Namaste, ma'am.
Namaste. Dr. Samuel joined all the way from
Namaste.
Africa. Yeah. Thank you. Thank
Thank
you.
you, ma'am. Thank you,
Hello,
ma'am.
hello, Dr. Upma. Upma, madam, how are you?
Fine, ma'am, fine.
Nice to see you. Okay, okay. With this, we are winding off for today.